Well, good afternoon and welcome to GPA Live. I'm your host, Ron Aaron Eisenberg, and delighted to have you on board. We come to you every Saturday in an effort to bring you the latest on dealing with chronic pain. We know that nationwide there are literally hundreds of thousands of folks who struggle with chronic pain. So every week we bring on an expert who can talk about one aspect of pain. Some weeks we talk about how to address pain in alternative medical ways. We talk about acupuncture. We talk about all kinds of issues involved in chronic pain. And today we take up opioids, opioid abuse, what to do if you get hooked. And our special guest, Dr. Marianne Pinkston, who is a pain warrior herself, battling rheumatoid arthritis. She's also facilitator of our new GPA Warrior Support Group. Now, ordinarily, we have Susan Blackwood join us at this time, but Susan is on special assignment today, so I'm going to fill in for her, which is a real difficult job, by the way. Susan is president of the Global Pain Association, and what the association strives to do is to help people living with pain by improving their quality of life through education, resources, and providing a community where they can deal and be helped by others who are also faced with chronic pain. GPA Live is one of those resources, and it's the newly formed GPA Warrior Support Group, a support group which is facilitated by our special guest today, Dr. Marianne Pinkston. And the support group meets the first and third Tuesdays of the month from 7 to 8 p.m. If you want to know more about the Global Pain Association, go to globalpain.org and you can get all the information you need. If you've got a question you want answered, just send an email, info@globalpain.org. Now, I want to bring on in just a moment Dr. Pinkston. She is the owner and head of Pinkston Medical and Wellness Clinic. Dr. Pinkston is certified in family practice and integrative medicine. She's a board member of GPA and chronic pain warrior herself, battling rheumatoid arthritis. She is a facilitator of the new GPA Warrior Support Group. She discovered she's suddenly on camera.
Sorry, I was trying to share the feed,
Okay, good. Dr. Pinkston is also a specialist in hormone replacement therapy, and she also directs a weight loss program. It's hard to believe when you look at her on camera that she lost 162 pounds while suffering chronic pain. Show us your guns. Let me see that again.
That's right, yeah.
There you go. Wow.
That's tough.
So, Marianne, for those who are joining us in the chat room, please share this program. It's easy to do, and you expand our reach, and it'll make us feel good. So you want to go ahead and share it.
Please
share it widely. Thank you. Dr. Pinkston, it's so great to see you. Talk a little bit about your own struggle with where you're going there.
I'm sorry, my battery just told me my battery's low. If we're going to have a technical difficulty, let's have it. So there you go, right?
Okay.
Sorry about that.
In?
Yeah, I plugged it in. We're good.
Oh, cool. Sorry. Talk about your own struggle with chronic pain.
Chronic pain has been with me for 15 years. Chronic pain is something that, and we'll talk about this some today, but, people will look at you and they don't know that you're having chronic pain. They can't imagine. You look great. You don't look like you're in pain. You don't have a deformed leg. You don't have a cane. You don't, and you may, but there are a lot of people who don't. So when you have chronic pain, that is something that is an internal struggle that most people don't recognize. And it's such a shame too, because that brings in a believability factor. People don't really believe that you have pain sometimes. Maybe they believe you, but they don't believe it's as bad as it is. And it can be horrible. And the worst part about it is it's with you 24/7. There are good days and bad days, good hours, bad hours, but it's with you always, and it's at the back of your mind. And if you're not in pain, you're waiting for the next day because you know you're going to be in pain. So it's just a terrible ordeal. So I've had it for 15 years and decided to really get into the psyche of it, into the treatment of it, and try to help people. And Global Pain Association has made this completely possible, and I'm so thrilled to be here. Thank you so much
Now,
for having me on again.
rheumatoid arthritis affects the joints.
Yes.
So you end up with pain in every joint, from fingers to elbows to shoulders to knees to hips, right?
Right. Well, and it's funny, even, sometimes the lower part of the back of my neck, but it also gets into the TMJ joint up here, chewing sometimes. That's when I know I'm really in trouble. And it's my left ankle is fused, pretty much. It's so damaged, it's pretty much fused. My both of my thumb joints, I think, are at the point where I probably need joint replacement now. I'm kind of going back and forth between whether to just fuse it or get it replaced. It's crazy, but I still do what I do. I'm not going to let it stop me. I gave up my life to chronic pain for several years, and that's not possible. You can't do that. You've got to give your life back.
Dr. Pinkston, when you say you gave your life up, that's when you were living in front of the refrigerator.
Yeah, well, living in front of the refrigerator, certainly boxes of food under my bed to deal with the stress, to deal with the pain. Carbohydrates are a very powerful tool when you're trying to deal with the depression of it. I was depressed. It was terrible. But, just always trying to find something that works, that helps. I had a small stint with the opioids too, and it's not fun. I don't like it. Nobody likes it. I promise you. It works, but it takes over your life. It's not nice.
No, that's what we want to do.
Strongly about this.
That's what we want to talk about today.
Yes.
Is opioids and opioid abuse. Now, everybody hears the word opioid, but not everybody understands which drugs are opioids.
Right. So I will bring it back to a couple of names for you. People don't know that Tylenol with codeine is an opioid. Tramadol is an opioid. Hydrocodone, oxycodone, Percocet. There are the larger ones. People have all heard of morphine and fentanyl, maybe, and things like that. There's also methadone, which is used for heroin withdrawal, but can also be used for chronic pain and opioid withdrawal as well. Those are kind of the larger names.
So how did we get to a place where so many people are hooked on opioids?
Well, chronic pain, I explained to you already, which, how chronic pain does take over your life. And so you are always trying to find something that will help. And we got to a point where one of my slides, and you don't have to bring up my slides quite yet, but one of my slides explained, well, actually, that is my first slide. Maybe we can go ahead and start right there. And so where it started. So in the 1990s, the pharmaceutical industry really came across with a campaign to tell doctors that, hey, we are not as bad, and we have made formulations now that, patients are not going to get addicted to, and really, started the campaign to get us to use opioids again. And patients are always hurting, and you're always looking for something in the pharmaceutical industry said, hey, this is something that you can do now, and we're not going to hurt people. And we're very reassuring in that. So we began to battle the addiction status grew at that point, and we started to battle it up until the mid 2000s or late 2000s. The early 2000s, like 2010. When prices started to skyrocket with meds, with the insurances, and we were able to, the industry was able to develop some more non-habit forming, long-acting opioids that we tried to get patients to turn to, and they would help, but they wouldn't maybe help as much. And I think there's a factor of energy and feel good. So sometimes when you take an opioid, you get a little bit of a kick and an energy to it that helps you get up and get things done. People call it a high. Maybe it is a high, but when you feel so badly and you take these medications and you feel good again, you may feel normal while somebody normal taking it would feel high. So it would do that, but it lost that kick to it that way. So I don't think patients really liked it as much. So they turned to more of a street drugs, because doctors were told, do not give these short acting medications. You have to give the long acting ones to be less habit forming. So I think patients turned to the street to get their meds. We also had an increase in fentanyl from China that became widely available. So when you hear about the death rate with opioids, they're primarily at a late day. It's because of people mixing things, and it may not be chronic pain patients actually that are dying so much as people who are mixing medications from the street and fentanyl from China.
All right, let me ask you a question, and I don't mean to stereotype, but
No,
let's take your run-of-the-mill, average, middle to upper middle class family, which is not the stereotype of people buying street drugs.
Right.
How do they discover and know where to go to get fentanyl and to get heroin?
You know, that the street side of things it's everywhere. You just have to ask a question sometimes of people. They can direct you to places. It's out there and it's easily found. And I think that even if there is, there are some people who get medications from doctors, and then like not the fentanyl or the heroin side, but even just hydrocodone or codeine or those tramadol and things like that, they can get prescriptions from their doctors and not take the medication, but turn around and sell it. And it has a very high value. And they make sure that people know who they are out there, a kind of an undercurrent. It's very easy to find.
And a lot of us remember when the late Rush Limbaugh was arrested buying street drugs, something you would never believe.
And you know what? Not to defend it, because it's not right. And he paid his price, and what he did, whether you love him or hate him, what he did was wrong. He knew it. But I think what happens to patients is a tolerance issue. So when they are taking, they start out with a small, light, so to speak, substance, maybe codeine or tramadol, which is really not very heavy, so to speak. And it helps their pain, and they take it for a little while. What happens in the body is the body becomes tolerant, or you become immune to it after a short period of time. So that little bit that you're taking doesn't help anymore. So you have to, increase the dosage. So every couple of weeks or months or so, you have to increase the dosage. Then you change to a heavier or a different molecule type, and you take that, then you increase that dosage. Then you start, adding on, and you just keep chasing this relief and even that energy level, which, like I say, people call a high. And yes, it is for some, but for some it's not. And even the high goes away after a while. You don't even feel that anymore, but you just have to keep going up. And whenever, I think there's a lot of maybe the community and some physicians don't really understand that entirely. And they think people are drug seeking and they won't go up on their dosages. And I think sometimes it becomes a clouded.
Well, we've lost your sound. But while we're trying to get her back, one of the other items on this slide that's really pretty important is how medical science failed with the lack of alternatives. Drugs that would do what opioids were doing, but were not effective. At the same time, visits with patients under Medicare, especially, were shortened. So patients didn't have the time they needed to talk with their doctor about a potential addiction to opioids. And then there are people who can't take NSAIDs, like Aleve. They can't use those medications. So we're back to help me, I'm in pain. And Dr. Pinkston, do we have you back? Do we have you back, Dr. Pinkston? Well, we do not. And maybe we need to call her and send her a text and let her know that we're not hearing her. Now, the problem with opioids is really pretty simple. They work. As Dr. Pinkston wrote in this slide, after years of pain, unrelieved by everything tried over the counter.
I am here. I am here.
Well, nice to have you back.
I am so sorry.
We're talking about opioids work, and that's part of the problem.
Right, right. So with the opioids, they do. That's part of the problem. So when you've graduated this level, and I think that doctors sometimes or the community doesn't understand, you have to take more. I think patients get clouded in their judgment a bit. You know, after you've taken opioids for a while, your brain really, the chemistry does not work the same, and so you will go back to to the street or whatever to try to find, or a friend will give you, medications or tell you where to buy some or sell you some or give you some, and I think that's what Limbaugh or people like Limbaugh get into. And maybe he was fully addicted and just wanted more. I don't know. I can't speak to that, but it's a problem that I think just about anybody can get into and not realize it. It's terrible. It really is terrible.
Describe for me what addiction looks like.
Okay, so addiction, and let me kind of back up maybe and make a distinction between addiction and dependence. So dependence is, well, let me flip backward then and say addiction is where a person maybe doesn't need the medication, or they do need the medication, but they begin to use it inappropriately. So they will go to the street and buy something knowing that they're lying to their doctor and lying to their family. Maybe they are lying to people trying to get more when, they are just trying to chase a high, or, they'll do something to harm themselves knowing it's harmful. And dependence is completely different. Dependence, your body is addicted to it, so to speak, but really it's dependent, where if you've taken it for so long, if you don't take a dosage, you go through withdrawal. So you just have to take a dosage to not go through withdrawal. But you don't lie to your doctor. You don't change pharmacies and sell things or buy things on the street or whatnot. There's a huge difference between those two.
So I remember you telling me off the air that the dog ate my homework. People will try, I dropped my pills down the drain, or
yes.
One of my kids tore up my prescription and I need another one.
Right.
All kinds of excuses,
yes,
which you as a medical provider have heard before.
Oh, many times, many times. And so it makes it difficult when it really happens to patients. There are times where that happens, but when it does, we have heard it so often, we don't know who is trying to get, by with it, so to speak, and who isn't. Right. So you have to just make a hard, fast rule that you just can't get any more when that happens. It's just, sorry, Charlie. And that's really a difficult thing to tell somebody when they're a legitimate patient. But sometimes you don't know they're a legitimate patient or not. You don't know when they're trying to divert and get by. And it could be a normal, great person who you work with at the office. It could be your neighbor. It could be your best friend. It could be the president or Rush Limbaugh. These are situations where these are not people who are look homeless, or not to degrade anybody, but who may not, what you think of when you think of somebody who's addicted to a medication. You don't know, you can't see it.
And when you talk about patients are still in pain,
yes,
whether they're addicted or not, or dependent or not, they're in pain, and they're going to look for something to help relieve that pain.
Really, they are. And there are so many alternatives that people can use. And it's really a shame, because this is what happens when people take opioids. So it decreases your brain chemistry numbers. So serotonin, norepinephrine, and dopamine, all of those brain chemistry hormones are there to make you feel not depressed, to make you get up and go, to make you feel motivated and interested in life and enjoying life. And whenever you take opioids on a long-term basis, it mutes that response. So you don't make those brain hormones. You begin to lose motivation. You begin to feel more depressed. There's also a change in your pain, as in where, yes, you're hurting. When you take this medication, though, it tends to change your pain perception and your pain tolerance. So you actually perceive your pain more. and you require more medication. And it's a cat and mouse game then, or which came first, the chicken or the egg, whatever analogy you want to use. But, it increases your pain and you don't realize it. It also decreases your testosterone levels, and testosterone is very important to your get up and go and your ability to think clearly and, not forget words and have brain fog and things like that.
And it's a hormone that men and women both need.
Absolutely. So that's what I do on a regular basis every day, talk to patients about hormone levels, and it is for men and women. But it also, and this is to feed your point, is it changes patients' thinking and ability to judge a situation. So your family will look at you and, you're falling asleep during dinner, or, you're a TV show and you're just not joining life anymore. You're just not, getting out there, and you seem maybe more depressed. You think you're better. You think the medicine is making you better, and you perceive this much better world, but everybody's looking at you and they don't see the same person. And I had a discussion, we'll talk about this in a minute, but I had a discussion with a patient's husband in clinic the other day. He was very honest about the situation and said that he lost his wife. She just disappeared, and her personality was gone. And you ask her and she's like, well, I'm great. I'm fine. But I know she lives with horrible pain. And, that pain was getting out of control though, because of the constant opioids. And so you can see what a terrible disaster it is.
And then you talk about the fear of being in pain.
Yeah. Well, and that's what happens to patients. I think if they are not getting their medication, I know that there's a patient that will, call at 5 o'clock on a Friday afternoon, where's my pain medication? And, we think that they're drug seeking when really the patient is just frightened. And, you didn't call my meds in yet. I may go through withdrawal this weekend. And then what if I get into that terrible pain cycle without my meds? I'm going to hurt so badly. They're in that fear. And, people just don't understand that. And if you've never taken opioids, or, and two, when patients are with their loved ones, like I say at the beginning of the show, when you look at patients, you can't see their pain. It's something that you just can't do anything but ask the patient to give you a score of how much pain they're in today. They don't look like it. And so nobody understands this deep, dark world that you get into over these medications and just your pain in general. It's terrible. So then what about my side of things, right? So I'm the doctor and I'm treating patients. And what happens to, what do chronic pain patients need to understand about the doctor's side? So these days, with all of the new rules and regulations that have developed over the last 10 years or so, we are under the thumb of the DEA and the Texas board, and I think very appropriately. But what we are under so many rules now, and licenses are taken away on a regular basis for these medications. And so we have a genuine fear of liability. The other thing too is we can be treating a patient. We understand our patient, have a great relationship with our patient. Something happens to the patient and the patient would never, understands where we are and what we're doing, would never sue a doctor. But the family comes in and they don't see the situation and they don't understand. They've never been in the appointments or whatnot. And they tend to sue doctors over situations they don't understand. And so there's a huge liability. We also we're human. I think sometimes doctors, I'm not like this, but I think doctors are afraid that they might not be liked or they might lose their patients. Like, I'm not going to give you these meds. Well, I don't like you. You're a terrible doctor. And then they hit you on Google or, whatnot. And so you're trying to preserve the patient relationship, but you want to help them and do the right thing for them. But it's sometimes very, very difficult to decide which is, where that fine line is. Addicted patients, dependent patients are very, very manipulative. And it's people you've known for a long time and you have every reason to love and trust, but they are in an addiction. And so, like I say, it changes their judgment and their thinking. So they tend to lie and manipulate, and you believe them because you've been with them for so long. And so there's a fine line there too. And it's hard to know, are they addicted or just dependent? And there are stigmas and stereotypes that come with that, like you mentioned stereotypically a while ago. The huge stigmas and stereotypes that lie there between the opioid world and trying to help chronic pain patients and be a good doctor and treat your patient's pain. There's too many stereotypes and stigmas that are difficult to overcome, and that's what we're trying to do today, is describe some of those things so that people understand from both sides, doctors and patients. And, what about the insurances are all over my back all the time about, they pay me so little, so I've got to see patients every 10 to 15 minutes and pack the clinic. Do I really, in 10 or 15 minutes, can I really address this problem appropriately with a patient? There's no way. So it takes a lot of time. And, it's the flip side of that too, is that patients sometimes will look at a doctor and say, hey, you don't know how I feel. You've never been in this kind of pain before. They can't do that to me. I can certainly speak to it. And I think that makes a great ability for me to work with patients on this level, because I do understand. I understand both sides, and that's really nice. And so then there's the elephant in the room. We all know that this patient has a problem, and we've got 10 or 15 minutes to address it. So how do we address it? Maybe we'll do it next time, or maybe we'll try to set up a longer appointment, but the elephant's in the room and you don't speak to it. Everybody knows that there's something wrong, but nobody talks about it. And that is a common practice, not just for doctors, but for patients and their families too. There's always the elephant in the room. You know what I mean?
And you don't want to bring it up because you don't have time to fix it.
That's right. And I may not even have the resources sometimes. Now, I feel like I've got plenty of resources for it, but as a family practice doctor, I don't do procedures or things like that. But that's where I opened up my world over the last 15 years to more integrative style. I've got a great CBD product or things like that we can do. But I also have great abilities to refer to some fantastic pain doctors. Dr. Ellen Lynn, who is a major part of this group, and her doctors on staff, and so many other doctors in this town. There are some fantastic pain doctors who can truly, truly help. So now, what about?
Go ahead.
Okay, I'm sorry. Then the spouse, the friend, or the family story. Again, I kind of keep honing in on this point, but yes, they do look normal. And they'll say, that doctor just keeps prescribing that medication, and, what do we do about it? And my loved one just doesn't see it. They've just disappeared from us. And if they could see it, I lost my wife, I lost my parent, lost my friend. And then the patient truly is in denial. And I think that what I need for spouses and friends and families to understand that you need to show up to the appointments if your family member will let you go. Sometimes they hedge that, and it's difficult, or you can contact a doctor. I cannot speak to a friend or a spouse about that patient's personal matters, but the spouse or the friend or somebody can come talk to me, and they can tell me their feelings and their story. I can't say much to them because of HIPAA and privacy, and I would never break anybody's confidentiality, but you can go and you can talk to their doctor.
But the patient can waive HIPAA if they are asked, and if they choose to do so.
Yes, they can. So they can, they can tell me, if they tell me it's okay to speak, or they sign a form and put the name on it, they can tell me that I can open up and talk to their family member or friend. So yes, and some patients do. I think it's best if they come to the appointment, though. If I could get more people to bring their spouses or their significant others or their family member, or, so forth, to the
caregiver.
Yeah, the caregiver, definitely for sure that too. Yes.
And then what do you mean by denial of patient?
So I think that patients, if they are in a sort of denial, if they don't see, if they're not at a place where they understand that everybody's looking at them and seeing a different person there, that lack of motivation or that muted personality and or depression or whatever, they don't see it. They see themselves as okay. And then they also get a bit defensive, saying, you don't know, I know you don't like me taking this medication, but you don't know how badly I hurt. You're not me. You don't live in my world, and you get sucked in, and you deny the fact that these opioids are actually hurting you, and that there could be other ways, because you are so afraid. You're so afraid to do something different, because they work, but they do change your brain and make you want to stay on them. There are options. There are other things. You just have to have a doctor willing to walk through the fire with you and communicate and get you through it.
And what have you learned as a doctor?
Well, a lot. I think that I am able to see into that world, and I do care very much about it. This is a very, very important, very passionate subject for me. And I recently, in the last year, I finally made the decision to stop prescribing them entirely. My patients, who I had many of them that were very close to me, I love very much, I really had to deliver the bad news that I would no longer be able to, to help them with those prescriptions. And it was a very difficult thing to do. I saw patients go through their fear that I was going to abandon them, just cut them off and abandon them. And I tried very hard to make sure that they understood that was not what was going to happen. I was able to understand the differences over these years, watching patients and truly communicating and getting honest with people, the difference between addiction and dependence. And I don't know that that's really taught in medical school or residencies. And I don't know that we really learn that when we're out. And that's such a big difference that doctors and staff and friends and family need to understand. There's a huge difference. And so I could see that. I feel like over the years of prescribing, I've missed so many of those opportunities, again, because of those things, the time factor, the elephant in the room, not wanting to, having enough time to go through it with patients and communicate. But I found out you don't have to do that in one appointment, and then I just take the time. I'm not one of those doctors that stick to that 10 to 15 minute rule. So I just take the time if I need the time, or schedule them at an appropriate time we can do it. And not long ago, whenever the story that I began a while ago with this patient and her husband, that affected me so deeply. I was so happy to meet him finally. I'd seen her for 15 years, and she had been married only a couple of years. I'd never met him, but we finally were able to get her off those medications and refer her. And so she got to a pain doctor and is off her meds and whatnot, doing so much better. And he said, I got my wife back, and I'm so glad that you finally cut her off. And I said, well, I didn't cut her off. We made arrangements, we fixed things, but he was so thankful and so happy about the whole situation. And that spoke to me that I did the right thing, by stopping prescribing these medications now, and staying with people, not punting them off and not getting rid of them, but really staying with them and getting them through the process. That was a much, much better process, much better thing to do for people.
And he got his wife back.
What's that?
He got his wife back.
He got his wife back. And that will stay with me forever. Him saying that, it was really amazing story. But the light at the end of the tunnel that I mentioned there is that, that we discovered that people needed to stop. There's an opioid crisis. And I've fought it for a long time, saying people don't understand these medicines work and they need this. And then, then the board rules came down where I had to see people once a month and check their urines and basically I felt like I was going to start doing muscle biopsies or brain biopsies next or something, all those rules. But it was worth it. It really was a good idea to make sure that patients are removed from these medications and find some alternative therapies.
Well, that's
very
pretty
important.
cool.
Yeah.
Well, this has been great information.
Thank you.
And it all comes down to science and understanding.
It does. That's the communication factor. I really, science is science. It's steadfast. It has its boundaries. Understanding doesn't. Understanding has no boundaries. And I found that communication and just getting into these patients' world, when a patient comes to see me, I'm exhausted at the end of the day because I wind up putting myself into 20 patients, shoes and heads and hearts all day long, because you really do have to go and feel what the patient's feeling and understand what they understand their world. And I really found that by finding that understanding with people and communicating, letting them be honest and tell me, yes, I feel addicted. And then me saying, okay, I'm not going to rip this out from under you. We're going to find a way and we're going to work on it together. We communicated and got honest. And that is the barrier breaker right there. That is the thing that is so important. Get them off these meds, get their brain chemistry back, get them back to where they're able to see what they just went through then and understand what their family and friends were saying. It's not a judgment. It's not a criticism. It's real. But so is your story. So is your story of suffering and pain and fear and everything. That's real too. We just have to communicate about all of those things.
Well, I want to thank you for this incredible presentation. And for folks who are concerned, either for themselves or for a loved one, start with your PCP, raise the issue,
Yes.
Get a referral to Dr. Lynn, for example, who is a pain specialist.
Yes.
And you don't have to be alone.
No, you don't. No, this is not something you can do alone, and you should never do alone.
Wow.
Never just stop your meds either. Don't do that. That's another danger. I think a lot of patients sometimes will think, I just want off of this, and then they'll just stop. And it's a withdrawal can be deadly, and it's a terrible thing. Please don't just stop your meds.
All right, now I need you to put another hat on.
Okay.
Take off your doctor hat.
All right. Where's my other hat?
And put on your global pain board hat.
That's easy.
Because normally we talk to Dr. Susan Blackwood at this point, but she's on special assignment at the moment.
Right.
And she talks to us about the Global Pain Association. Why are you a member of the board, and how do people get involved?
Right. So this association is a game changer. I've been a part of associations. I've done many of these things. You guys are a great group that really have your heart in the right place. And so I really want that. Really getting involved has changed my world completely. And I really want people to get involved. So I'm asking for two things today. And one is for people to go to the website. So globalpain.org and join the emails. I want people to join my support group with the Global Pain Warriors on the first and the third Tuesday of every month at 7 p.m. And that is all over my
free.
It's free. It's not just for pain patients. It's for their caregivers, their spouses and friends and family. It's for everybody. No certain pain condition, any pain condition, any chronic illness, really. So the other thing too is and there's an email. You guys, when you go to the website, there's an email that you can join and get a weekly. They don't email you to death, so it's not that, but you can get a weekly email telling you what's going on, what's available. You can email Global Pain too with any questions. And the other thing that we're asking people to do also is become a sponsor and to donate. We do this for free. I'm not paid to do this, and I wouldn't dare be paid to do this. This is wonderful to share all of this and to speak for this group and represent. But we have to live. We have to do this and survive somehow. So we definitely need sponsors to sponsor the weekly series and whatnot. But we also need people just to donate. Anything would be great. So please go to globalpain.org. It was on the /donate. She had it up there a few minutes ago. But please donate and support us. We need it.
Marianne, thank you so much.
Thank you.
And we will talk with you again very soon, I am sure.
So.
Coming up next Saturday, March 13th at noon, right here on GPA Live. The topic is my foot pain. And a lot of people have foot pain, me included. The special guest, Dr. James Ogden. And if you have questions you want to ask, email those, info@globalpain.org. So next week, March 13th at noon, foot pain. I'm Ron Aaron Eisenberg. Thank you for joining us today on GPA Live, and we'll see you next week. Have a great weekend, everybody.